All right, so let's see, I think it should be on, yes. All right, so why don't we go ahead and get started here. So good morning, good afternoon, good evening to everyone wherever you are. My name is Akwi Asambang. I'm an interventional gastroenterologist at Brown University. I am also the board president and co-founder of the Pan-African Organization for Health Education and Research. We have, as part of our educational series, just an amazing panel. I'd like to thank Dr. Lottie Hachaambwa for joining us today. Our co-moderators are Natasha B. Sichula, who's a POHER scholar, and Hannah Simba, who is a POHER volunteer. We will have a special guest joining us later on. I'll just have to make sure that their technology is working and they'll be able to share their experience. So once again, just like with all our prior events, this event is for you. The idea is knowledge sharing. Let's get rid of the stigma. Let's talk about these ailments, and let's go. All right, so I will pause and get out of the screen, and it's all over to you, Hannah and Natasha. Thank you both.
Thank you so much, Dr. Akwi. On behalf of the POHER scholars and volunteers, we would like to say thank you so much to Dr. Hachaambwa and all the other distinguished guests that we're going to have shortly. And also to say thank you so much to the POHER board and executive team for giving us this opportunity to share more information about the HIV and AIDS pandemic with our communities in Africa and all over the world. I just wanted to also give you a brief description of what POHER means for those who are new to this. So POHER is Pan-African Organization for Health, Education and Research. It is a non-profit organization with a focus on the soundness of the health sector as the cornerstone of social and economic development of all African countries. So the mission statement of POHER, the mission of POHER is to improve health awareness in African communities, to promote and advocate the creation of partnership between health professionals in Africa and overseas. So that is what we're doing. We're bringing diverse doctors together to discuss different topics surrounding health. And the other one is to mobilize material resources for healthcare services in Africa. So today we have the privilege of having Dr. Hachaambwa and Dr. Mogomotsi, and we're going to be commemorating the HIV and AIDS day that was celebrated this month. If you do not know, December is the month which we commemorate HIV and AIDS. So I'm going to now introduce our distinguished guest speaker from Zambia, Dr. Lottie Hachaambwa. He's such an amazing physician and scientist, and he has so many accolades to him. Dr. Hachaambwa graduated from the University of Zambia School of Medicine. He finished his internal medicine residency at Kettering Medical Center. He later completed a fellowship in infectious disease at University of Rochester Medical Center. He's board certified in internal medicine and adult infectious diseases. Dr. Hachaambwa is currently based in Zambia, where he provides technical support for the University of Maryland's HIV care and treatment programs and graduate medical education programs in collaboration with the University of Zambia. He's the CEO of Center for International Health, Education, and Biosecurity in Zambia. Wow, what an amazing biography. We're so honored to have you here, Dr. Hachaambwa.
Thank you. Good morning, everyone. I'm glad to join you this morning and afternoon.
Awesome. And now I'm going to give it to my co-moderator, Hannah Simba, to introduce herself and our other speaker for today.
Thank you, Natasha. Hello, everyone. My name is Hannah, and I'll be co-moderating this session with Natasha. And I also have the honor of introducing one of our panelists, Dr. Matshaba, who is the Assistant Clinical Professor of Pediatrics Retrovirology at the Baylor College of Medicine and the Executive Director of the Botswana Baylor Clinic. He's a graduate of the University College of Dublin, Ireland. He worked as a medical officer in Botswana from 2005 to 2008 during which time he spent 1 year as a physician in training at the Botswana Baylor Children's Clinical Center of Excellence. He completed his residency training in pediatrics at Baylor College of Medicine. And in 2014, he moved to Eswatini, formerly Swaziland, Center of Excellence as the interim executive director, and later returned to Botswana at the end of the same year. He's the principal investigator of several studies, including the NIH-funded Collaborative African Genomes Network study, and leading a team of researchers from 6 institutions and 4 countries. He's an in-country PI of the individual findings of the genetics research in Africa, the HD Africa ELSI Collaborative Center. He's the co-chair and incoming chair of the H3A Africa Steering Committee. He's also the chairman of Botswana's National HIV Syphilis Elimination Validation Committee. Currently, Dr. Matshaba is the scientific advisor for Botswana Presidential COVID-19 Task Force. He also sits in several Ministry of Health and Wellness committees as the pediatric HIV expert, the Botswana National HIV Guidelines Committee, TB and HIV Integration Technical Working Group, HIV Drug Forecasting and Procurement Committee, TB HIV Drug Resistance Technical Working Group, Adolescent HIV Guidelines Committee, and among others. He was awarded the International Lifetime Achievement Award by the Society of Pediatric Gastroenterology, Hepatology, Transplant, and Nutrition in India in 2016. We are very honored to have you, Dr. Matshaba, and welcome.
Thank you.
Awesome. So we have we're going to have a discussion. So feel free to ask questions in our comment section, and on Facebook we're live. Feel free to type in your questions. We want this to be a collaborative conversation. And so we're now going to give it to Dr. Hachaambwa to just tell us a bit about the work he's doing pertaining to HIV, and then we have a couple of questions.
Good morning. I'm sorry, could you repeat the question? Sorry, the sound was breaking.
Oh, just like tell us a little bit about the work, your background on HIV/AIDS, and the type of work that you're doing currently.
Oh, okay, sure. Yeah, so as you mentioned, I'm an infectious disease physician. So my work primarily consists of teaching HIV and infectious diseases at the School of Medicine in Zambia, and also some of the time with the School of Medicine in Baltimore, in the University of Maryland. But I'm also doing some work here in Zambia, focusing on prevention, HIV prevention, focusing on adolescent girls and young women, and also key populations. That's the bulk of the work that I'm involved in at the moment. And then also doing some research on reducing mortality in HIV infected individuals when they get admitted to the hospital, reducing inpatient hospital mortality. Thank you.
Thank you so much.
And Dr. Matshaba, would you also want to briefly speak about the work that you're currently doing?
Oh, we can't hear you.
It's because I'm on mute. Thank you, Hannah, for the kind introduction. I have to say, I didn't know you were going to read the whole of it. I would have shortened the intro, but thank you for your kind words. By training, I'm a pediatrician, as you have already heard, and my work essentially centers around pediatric HIV and other diseases in Botswana. So I'm the head of the Botswana Baylor Clinic, which is the tertiary HIV care clinic in Botswana. We are centered in the main city, Gaborone, but we do care for children from across the whole country. We currently have a relatively small population of children at 2,500 that we care for, and about almost 2,000 elsewhere in the country. Our services generally, we provide testing, care, counseling for children, adolescents, and young people. Our work essentially has been around providing adolescent or child-friendly clinics across the country. We do this through clinical care, training for physicians, nurses, as well as other cadres that care for children. For example, we have trained about 96% of our teachers on how to deal with children with HIV. Beyond that, we do research. As Hannah mentioned, we do quite a bit, especially around adherence issues, specifically surrounding adolescents. We do a bit of stigma work as well. And then recently, as of 2014, we started doing genetics and bioinformatics, again surrounding children with HIV. We also do advise government and international bodies, as mentioned. I'm trying to just summarize what we do, because it's quite a bit that we do for children with HIV in Botswana. Okay. We are part of a large network. I'll just wrap it up. We are part of a large network called BPI. It's Baylor International Pediatric AIDS Network. It's in about 20 countries. So we are a small part of that, and probably are the largest provider for children with HIV through that network. Thank you.
Thank you so much. I really enjoyed learning about the work that both Dr. Hachaambwa and Dr. Matshaba is doing in Zambia and Botswana, respectively. So Dr. Matshaba, you mentioned a word when you were doing your description. You said adherence. So like, if I am a person who has zero knowledge on HIV and AIDS and the word adherence, how would you explain it to me? So what is HIV and AIDS and how is it transmitted? So Dr. Matshaba, you can tell us about it. And then Dr. Hachaambwa, you can also tell us more about the adherence of HIV in Zambia and how it is transmitted.
Okay. No, thank you for that question, Natasha. I think it's an important question because I think now we have heard so much about HIV that we forget that we still need to keep on reinforcing the information. HIV, as you know, in children is generally passed from mother to child, but we do get cases of children or adolescents who get it sexually, like adults. And the only way for survival is by being on treatment, and this is lifelong treatment. Because of that, there is need for the client to be what we used to call compliant. We used to use the word compliant instead of adherence to treatment. That means taking it as directed for the rest of your life. As you can imagine, for children and adolescents, it's not an easy feat, because children are growing, they're inquisitive, they are learning, and through those phases, it becomes a very difficult thing to follow and take their medicines. Therefore, we then, earlier on in the epidemic, we started talking about adherence, which now means there is responsibility for the client. It may be a child, the parent, or the adolescent themselves, to be responsible for taking these medicines. That's where the word adherence now comes in, because it's now jointly the clinician and the young person, adolescent, working together to make sure they are on treatment. And if this is done right, we understand that these children will grow up to be adults and have a much longer lifespan than when the adherence is poor. The reason we focus on it here is just like everywhere else, and I think Dr. Hachaambwa from Zambia will attest to that. Adolescents are peculiar in that they go through phases where adherence becomes a problem. So our work has been, what is the best support that we can give to these adolescents for them to be adherent to treatment? I'll stop there so you can add. I don't steal your thunder as well.
Yes. So Dr. Hachaambwa, you mentioned that you work mostly with women and girls and other populations about HIV. So tell us, how is it transmitted, and how is the adherence rates in Zambia? And then Hannah will take over from there.
Yeah, thank you for that question, Natasha. As Dr. Matshaba mentioned, so HIV transmission in adults mainly, it's through sexual transmission. And within the general population, there are certain groups where the risk is higher, obviously, than other groups. These would include key populations and priority populations. And in Zambia, and I'm sure a picture would probably be similar in Botswana, that young people, adolescents 15 to 24, sort of, especially females, tend to be more adversely affected by HIV. So we tend to see new HIV infections more commonly in that age group. And also, we also compare to boys, for example, and also compare to the other adult populations and young populations. So that's a particular group that at least my work currently is focused on. You might have heard of the DREAMS initiative by PEPFAR. So we're working on some of that work. And so that's one group. And the other population of adolescents that we get that have HIV infection are the ones that acquired it perinatally. So that's a group that I'm sure Dr. Matshaba deals with, and we do have that population. And when they reach the age of adolescence, depending on several factors, some may have lost parents in the past and they live with guardians and may have moved from home to home. So all those are factors that contribute to suboptimal adherence to treatment. So that, and then they also go through, they're going through a growth phase. They interact with peers who are not on treatment. And the potential for stigma, which is what we're discussing this afternoon, one of the things we're discussing, is quite great. If none of their friends at school take any medicines and they have to take this pill or these pills every day in order to survive. So as you can imagine, that's a very big challenge on these young people. So we try what we can to encourage them to remain adherent to that treatment. Fortunately, treatment these days is very effective and also has very minimal side effects compared to treatment that was available many years ago. So there's a lot that has changed that hopefully makes it easier for these young people to take their medicines. And also for the ones who are HIV negative, to remain HIV free. Again, this particular age group as a way of focus.
Thank you so much for that elaborate answer, Dr. Hachaambwa. Before I move on to the next point, I just wanted to find out if there are other modes of transmission. I know you have mentioned mother to child, and you've also mentioned sexual, but are there other modes of transmission that you'd like to highlight for HIV?
Yeah, so just briefly, the other modes of transmission, occupational exposure. So people that work in the health sector, they can get exposed in the course of their work. This could be injury with sharps. So needle stick injuries, splashes, or any exposure to blood and body fluids. So the way one can think of it is HIV can be transmitted by exposure to non-intact skin, meaning skin which has a cut, or mucosal surfaces. And these are like the surface that's found in the genital tract and also the oral cavity. So exposure to mucosal surfaces with any of the following fluids. So blood, vaginal secretions, cervical secretions, semen, and other bodily fluids that contain the HIV virus. So when there's exposure with those fluids and non-intact skin and mucosal surfaces, there can be HIV transmission. So needle stick injuries, and then also injection drug use is another common mode of transmission. And we mentioned sexual transmission, which can be heterosexual or men who have sex with men. Those are the modes of transmission. Dr. Matshaba may want to add one or two more, I think, perinatally.
Yeah, no, I think, Doc, you covered the most important ones. In terms of pediatrics, it's the same risk factors depending on how they come in contact, specifically the mucosal ones that you talked about. For older adolescents and young people, we get concerned more with drug use, which is becoming a lot more common. where they have less access to needles and safe use of these drugs. But I think it's just the same as what you have mentioned already.
I have a follow-up question for Dr. Matshaba. So I wanted to find out, when infants are being transmitted, like when they have HIV, is HIV transmitted to them through the breast milk, breastfeeding, or is it through the birth canal? How is HIV transmitted to infants? And is there a difference? Is there like a difference when a baby is born using cesarean section or the natural birth? Does that lower or increase the HIV, how the baby will have HIV or not?
Thank you. I think those questions take me to the early days of HIV. Very important questions. Transmission in pediatrics, when we say mother to child, it's multiple different modes. So the first part you can imagine is when the child is still in the mother's womb. So there is a risk that it can cross the placenta and go and infect the child. We think this proportion of those who are infected this way is relatively low compared to the next phase. So the next phase of transmission happens around the time of delivery. You can imagine delivery is a very traumatic, I don't know what other word to use for the child. I'm thinking about the child because I'm a pediatrician. You can imagine all of those things happening. Blood that Doc has mentioned becomes a factor. There are other secretions that during the birth process the child gets in contact with. So the risk of transmission is highest during this phase of the child's life. Following that, then the risk shifts to breastfeeding, which is where now some of it is seen in the breast milk, specifically if the mother is not on treatment. You do ask a question, an important one, on cesarean section, and it's a method that reduces the risk, because as you can imagine, now it's a surgically controlled process instead of the normal birth process, where now the child is safely gotten out of the womb and with less interaction with all these other fluids that we talked about. In the beginning, it was shown to reduce transmission, but over time, especially with the mothers being on treatment and being virally suppressed, where the virus, you can find it in the blood, then we went the route of normal, safe normal delivery. Beyond that, I think there are no other ways that a child can get infected beyond the 3 phases that I talked about. The next phase of infections then comes when the child becomes an adolescent and you introduce the adult type of transmissions.
Thank you so much. Hannah, you can go ahead.
So this will bring me to our next point of discussion, which are the current trends for HIV prevalence in Africa. So what are the current trends of HIV burden in Zambia for you, Dr. Hachaambwa, and Botswana for you, Dr. Matshaba, and any other African countries that perhaps you have worked in, and how do they compare with the rest of the world? We'll start with you, Dr. Hachaambwa.
Yeah, so Zambia is still quite adversely affected by the HIV pandemic. It's one of the countries, generally sub-Saharan Africa, I think, as Dr. Matshaba mentioned, that sub-Saharan Africa bears the brunt of the HIV pandemic compared to the rest of the world. So Zambia is in sub-Saharan Africa. So there's an estimated about 1.2 million people living with HIV in Zambia. And the prevalence, which is the proportion of adults aged 15 to 59 years of age. So the proportion of adults that have HIV infection is estimated to be around 11%, which is a decline from what it was around 2007. It was about 16%. And then it's been coming down 12%, and now it's about 11%. But that's still much higher than for example, in West Africa, where Nigeria, the recent NICE, the HIV survey that was done, we showed it to be very low, less than 2%. And then in other parts of Africa and East Africa, for example, they also have much lower HIV prevalence rates. So that's the proportion of adults that have HIV. And of course, we expect that to kind of remain stable because we have effective treatment now. And so it means that those people remain alive. It only get lower as we get new children that are born that do not have HIV infection. But the general trend, but there's another number that we look at, which is the number of new infections per year. So the last survey we had, which was nationwide in 2016, showed that for Zambia, it was around 0.6%. That's the incidence of HIV, the proportion of new infections that occur per year, which again is still quite high. So we still have a lot of work to do to get that down. Over.
Thank you. Should I go ahead?
Yes, Dr. Matshaba, you can go ahead.
Okay. No, thank you. I think when I hear the numbers that Doc is talking about, I get jealous because ours are higher. But I think the trend is the same in that he was talking initially around 15, now they are at 11% prevalence. Again, this is the number of people, total number of people who have this infection. In Botswana, we stand at 20.3%. It's one of the highest. I think we are the fourth or fifth highest in the world. The highest it has been was around 2000. The year 2000, when we were around 26% for the general population. Like he says, our incidence remains around roughly the same. Our programmatic data shows we're at 0.61. He talked about 0.6, so roughly the same. But our population is much, much smaller. Most of you may know that Botswana population is 2.3 million as of 2018. And out of that, just over 400,000, or around 400,000 people are thought to be infected with HIV. I think those are our general numbers, but if you now zoom into the adolescents, it's a concerning trend. Within the number, the 0.61 that I talk about, majority of it is in the young people. So new infections are happening in young people. About half of the new infections are in the 15 to 24 age group. This is concerning because this is the same age group where we know that condom use, adherence, all these other issues are a problem because of the phase of development that they are in. So we are working very hard to try and educate, since we have noted that in this age group, majority of them were not able to answer HIV questions correctly, meaning that the knowledge of how to protect themselves is limited. So there's a lot of work to be done. Yes, we have done well in reducing the numbers, but we still have a lot of work to do.
Thank you very much for bringing that important point. Natasha, you can go ahead.
Thank you so much. I was just wondering whether any of you doctors know which country has the highest number of patients with HIV.
I think that would probably be South Africa. Dr. Matshaba, what do you think? I don't recall exactly, but it would probably be South Africa.
Without being too political, yes, that is the recorded highest. I think if you look at the absolute number of people living with HIV, it's South Africa. You look at prevalence, though, it may be not be South Africa. In terms of prevalence, I think it's between us, Botswana, Eswatini, or Lesotho. Then South Africa follows after that. But it's a big, big problem. And these numbers, I think we have to be careful with, because you have to factor in the population and other factors in before we point fingers.
Okay. Yeah, I was just thinking that the more south you go in Africa, the more the numbers increase. So yeah, I was just thinking that. I was wondering, so you, Dr. Hachaambwa, you mentioned that West Africa and East Africa have less numbers as compared to the Southern African hemisphere. So is there something they're doing that we're not doing, or is there something that we can compare and try to adopt in our own countries?
Yeah, I think that's a hard question, I think, for which probably isn't a very easy answer. So there are certain things that are proven to be effective, and we're all working towards that. And we started talking about them. Let me just go back again to prevention of mother-to-child transmission. So learning from mother-to-child transmission and its elimination, the target now is to eliminate mother-to-child transmission. It was realized that when someone is on treatment, because in that situation, a pregnant mother would be put on medicine to prevent transmission to the uninfected unborn child. So the same thinking prompted similar thoughts for the rest of the population. So if you have that has HIV infection, or let me say a couple where the status is different, the serostatus, the HIV status. So if the HIV infected individual is put on treatment, the risk of transmission to the uninfected partner gets reduced. So since 2016, most of Africa has moved to promoting treatment for everyone. So as soon as somebody gets diagnosed with HIV infection, one doesn't have to wait for a CD4 count, which is a measure of the immune system. You don't have to wait for the CD4 count to reduce to a certain level. So as soon as someone gets diagnosed with infection, with HIV infection, they can be put on treatment right away. So that does several things, one of which is obviously reducing mortality, death from HIV, and also getting very sick from HIV. But it also plays a role in reducing transmission to other people. I'm sure we'll talk about this later on, but that's one of the things that's been shown to work everywhere. So it should work in West Africa, it will work in Botswana, it will work in Zambia, that when people are put on treatment, the risk of transmission goes way, way, way down. And then the UNAIDS has come up with these ambitious goals of 90-90-90. By 2020, the goal was to have 90% of the people know their HIV status, and of those that know their HIV status, 90% to remain adherent to treatment, that they remain in care. And then of those 90% that remain in care, 90% to have the viral load well controlled to the point where it's undetectable. When you check in the lab, you see how much virus is circulating in the blood, you don't detect it. So I think those are the things that I can talk about there. Treatment to reduce transmission, and then the 90-90 goals, which are part of the efforts by the UN to reduce HIV transmission.
Awesome, thank you so much. Hannah, you can go ahead.
Yeah, so we're going to move on to risk factors. And so the question is, what are the main drivers and risk factors for HIV infection currently? And I think you have touched on this a little bit in our discussion already, but if you could just summarize a little bit what some of the risk factors, or highlight some of them for us, and if they differ according to age in gender, and I'm sure they do. Dr. Matshaba, do you want to start? And Dr. Hachaambwa, you can add on.
I think Dr. Matshaba stepped out a little bit, so Dr. Hachaambwa, you could share the information with us.
Yeah, so the risk factors for HIV transmission, you could look at them from different angles. So maybe things that increase HIV transmission. So there's the virus itself. So the type of virus will affect how much of it gets transmitted. And then there's also the individual who has the HIV virus. So early on in infection, during infection, there's a period where the risk of transmission is very high. In someone who's just gotten HIV infection in the last 1 to 3 months, they're at very high risk of transmitting the virus to other people, including the period when they're in the window period, when the antibody test cannot detect the HIV virus. There is a very high risk of transmitting the infection to others. So if such an individual has unprotected sex, they can easily pass it on to other people. Another phase of the illness where the risk of transmission is high is in late stage, when someone has very advanced HIV disease. Again, the risk of transmission. This is from the perspective of the individual who has HIV. That obviously increases because the number of viruses in the body is very high. Now, on the part of the individual who is being exposed to HIV, some of the risk factors include the number of sexual partners they have, obviously. I mentioned key populations previously. So among these would be people engaged in commercial sex. They have a lot of sexual partners. And if those encounters are occurring without barrier protection, condoms, that will increase the risk of HIV infection. The presence of sexually transmitted infections, again, will increase HIV transmission because a number of sexually transmitted infections include breaks in the skin. And you mentioned earlier that any break in the skin will increase the risk of HIV infection. So breaks in the skin in the genital area. And then there's also, we mentioned certain populations, among the key populations, those who inject drugs, men of sex with men, those are groups where there's high risk of HIV transmission. So in summary, those are some of the things that increase the risk of HIV infection.
Thank you so much for sharing information about the risks of getting HIV and AIDS infection. And for all those who are viewing this live stream, please take note of that and analyze your lifestyle, or if you know somebody whose lifestyle falls under that category. So the next part of this discussion is that we're going to discuss the prevention and intervention strategies. Dr. Hachaambwa, could you please share with us, how can somebody prevent HIV and AIDS, and how can they help other people know more about HIV and AIDS?
Okay, yeah, so on prevention for HIV, there can be medical interventions, and we started talking about some of these. I'll probably start with that. Medical interventions include treatment of individuals who have HIV infection. So that can be termed as treatment as prevention. So individuals who have HIV infection, when they're on treatment, in a couple of the example that I gave, that will prevent transmission to the partner who is negative. An example is a serodiscordant couple, which means that a couple where one is negative, the other one is seropositive. So treatment is one of the main ways of prevention, to a point where now it has been shown that if someone is on treatment and the virus in the blood is so low that it's not detectable, HIV is actually not transmitted. So that's a very good thing, that when someone is on treatment and the viral load is undetectable, there's no transmission of HIV that occurs. And then there are also other prevention modalities. Prevention, post-exposure prophylaxis. So this refers to taking ARV medication after exposure to the HIV virus in order to prevent transmission. So this can be occupational exposure or non-occupational exposure. The non-occupational exposure is mainly through sexual activity. If someone has a high-risk encounter, they can be offered what's called NPEP, non-occupational exposure prophylaxis, post-exposure prophylaxis. And then for healthcare workers in the course of their duties, they can be given 28 days of HIV medicines, which are very effective in preventing transmission. And then continuing with the medical interventions, there's also pre-exposure prophylaxis. Prophylaxis is just medicine that's given to prevent something. So pre-exposure is before exposure. So before somebody is exposed to HIV virus, for people that are at high risk for HIV transmission, they can be put on pre-exposure prophylaxis, where they take two medicines, typically two medicines that are taken for as long as the exposure exists, and then they'll have reduced transmission. And again, you can think of populations that I talked about earlier, sex workers, men who have sex with men, in a couple where there's serodiscordance, where one is positive and the other one is negative. And then also in pregnant and breastfeeding women, at least in Zambia, we do give pre-exposure prophylaxis or PrEP in pregnant and breastfeeding women where their partner is HIV positive and the viral load is high. And if the pregnant or breastfeeding woman is HIV negative, then we do offer pre-exposure prophylaxis. So I talked mainly about them, the medical interventions for prevention. Since Dr. Matshaba is here, I can probably go on to talk about the behavioral interventions and other modalities, even some of the biomedical modalities of prevention of HIV infection.
Thank you so much, Dr. Hachaambwa. Dr. Matshaba, we're now discussing how somebody can prevent HIV and AIDS. Dr. Hachaambwa shared with us the medical ways of preventing it. Would you please care to share with us the non-medical? I think Dr. Hachaambwa said the behavioral prevention of HIV/AIDS.
Yeah, apologies, I lost some connection for some time, so I missed part of that discussion. So I may repeat what he may have shared already. But in terms of behavioral, I think knowing and education is key, because you can't protect yourself from something that you don't know. So for us here, for example, we realized there was a survey here in Botswana that showed that our adolescents, for example, about 47% of them actually know what they are supposed to do, which means the other 53% doesn't. So if you don't know, then you go into risk, and the risk leads to infections. So I think knowing about HIV, how it's prevented is key. The other is, as a society, deciding what risky behaviors are acceptable and promoted, and those that are risky are discouraged. I will give an example. If you look at some Western countries, for example, in Europe, where a lot of things are legalized that in Africa are taboo, their HIV control is much better. I'm giving a specific example about sex work. For example, if you are in Amsterdam, it's not illegal to get those services. What that means is that the society has decided this is acceptable, and we are going to make it safe. And that way, then the behavior is modeled such that you prevent a lot of these infections that would otherwise have happened because it's not regulated. I'm not, get me right, I'm not saying we should legalize anything. I'm just giving these examples of things that can be used to change behavior. The other is rewarding behavior that leads to protective intervention. This is in places where there are studies that have shown, I don't know if you have already talked about it, Doc, where there are financial incentives actually for not getting infected. This is where some programs in South Africa and I think in part in Zambia went on to give some financial incentive for those who test negative over time, and especially young people. And it was shown to actually work and keep them motivated. not to get infected. Again, all of these things, just like the medical interventions, are very difficult to implement, much more so for behavioral, because again, behavior is a learned response to different situations. And to change what people have learned their whole lives to this new behavior becomes a problem, much more than take this tablet and it will help you. So I think, I don't know which major ones I've left out, Doc. You'll add to what I've just mentioned.
Yeah, I think probably the only other one that everyone is aware of. So condom use does prevent HIV infection, and then voluntary male circumcision, which again,
correct, condom use.
Yes, condom use and voluntary male circumcision, and yeah. So just to mention the issue, reinforce the issue of knowledge. So in Zambia, similar to Botswana, the proportion of young people that had correct information about HIV was 40%. So that means 60% have incorrect information. So education, raising awareness among young people and about these HIV and also how it can be prevented. So obviously that will have a big impact. And yeah, so those are the main ones that we can think of.
Thank you so much, Dr. Hachaambwa and Dr. Matshaba, for sharing this valuable information.
Just to follow up from me, I'm a bit surprised with the percentage of people who do not have the correct information on HIV prevention strategies, or I mean, what more needs to be done? Because it feels as though the information is there, and I understand there's a lot of awareness campaigns, even national programs that are done to educate the public. But what more can we do at this point? And especially like Dr. Matshaba, you're saying with the 15 to 24, I mean, it seems like this is the age group that has access to a lot of information. So what more needs to be done to lower the new infections at least?
And is there a language barrier for some reason or not? What initiatives are you putting in place?
Yeah, thank you for that question. I think starting with your last question, I don't think it's a question of language barrier. I don't know about in Zambia, where you have 72 different languages. In Botswana, we only have a few. So what has happened over time is a lot of this information has been translated into different languages, including sign language as well, and then Braille for those who cannot see. So I think it's not a question of access to this information. Over time, which we are beginning now to see, if you allow me to digress a bit into COVID, what we are beginning now to see is people have become tired of COVID in 1 year. They just don't want to hear about it. So even though there's campaigns and campaigns after campaign, people just have locked themselves out of getting new information. So we believe that over time with HIV for 30 years, talking about exactly the same thing, especially the one that takes away people's rights to certain things and all of that, you get this complacency and fatigue because people are just tired. So for young people, I think what is key is continuously engaging with them, finding out what are the most important things for them, and then packaging your information in a manner that will be palatable to them. A 15-year-old in 2020 is not the same as a 15-year-old in 2000. So if you are still using the same information from 2000, it means you are missing the mark, because there's a lot more connectivity now. There's a lot more use of social media. There are actually other media that actually are countering what we are saying. So I think we need to move with the times. First, involve them in designing these messages and making sure they are palatable to them. And the second is remaining current as well, and making sure that what you are saying is the right thing for now. And I can tell you in 2-3 years, the same information that you have today will be less true, in 2 years or 3 years. So being involving them and then making sure that we are up to date with them, with the information, and being as open and truthful as possible. Because at the beginning, we saw this as a death sentence, but now it's something that you can live with a lot of complications that come with treatment, with transmission, childbearing, all of these things that are important to young people. So our messaging, I think, needs to have all of those things in place.
Thank you, Dr. Matshaba. So what I'm getting for you is we need more modern and more innovative interventions for behavioral change. Dr. Hachaambwa, do you have anything to add to what Dr. Matshaba has said?
Yeah, thank you. Just to add on, I think involving young people is really key. So both young people that are living with HIV and young people that do not have HIV infection. So involving them in the interventions that are targeted young people, towards young people. In some of our health facilities in Zambia, we do have youth-friendly corners, either at health facilities or somewhere close to there where young people can access information, they can hang out and do all kinds of things. And I'm sure in several Southern Africa, let me say, countries, they have programs similar to that, where they can have information, access services that prevent HIV infection. And I mentioned earlier of the DREAMS program, DREAMS initiative, which targets adolescent girls and young women to prevent HIV infection. It includes communication with parents. So sometimes it's difficult for parents to discuss sexuality with their adolescent children. So all that's part of the intervention that needs to be done. What's discussed in schools, the information that's discussed in schools. And as you may be aware that in the African setting, sometimes it's difficult to discuss these things, and so that probably does make it difficult to kind of discuss them a little more comprehensively.
Thank you so much for sharing that information. Go ahead.
I was just going to add that, yes, that's an important one. Parent-child communication is key, because I think adolescents generally spend most of their time is either at school or at home. So these two environments need to be conducive to discussing these difficult issues. So teachers and parents actually are, in our culture, we consider both of them parents to these children. So we need to train them, as I alluded to in my opening, that we trained about 96% of our teachers for this reason, that they are so important in the children's lives. I think the last one is more to do with mental health. I think a lot of our cultures, we generally try and sweep things under the carpet. We would rather not talk about them. This includes sexuality, this includes any issues that show weakness, specifically for the young women and the young men. We want them to be brave and be strong leaders of tomorrow, forgetting that they are still developing, and mental health is a huge issue. And under that, you can also squeeze in stigma, which remains a major issue for adolescents because they feel judged everywhere they go. It's a different type of stigma, generally from the adult side, but it's quite significant it can keep people away from getting the right treatment. I just wanted to add those.
Thank you so much. Now that we know about the prevention and how it is transmitted, I wanted to find out, what are the signs and symptoms of HIV and AIDS? What is something that somebody can look for if they are suspecting that they have HIV and AIDS?
I can probably start with what's called sometimes acute HIV infection, because sometimes it's not recognized. So when someone just gets infected with HIV, 2 to 4 weeks after that, they may get a sore throat, a skin rash, fever, diarrhea, nausea, vomiting, headache, and several other such symptoms. And most of the time when people get such symptoms, they may dismiss them. They may think, oh, it's something else. And actually, if they go for an HIV test, it may come out negative. But if someone is aware of a risky encounter 2 to 4 weeks previously and have such symptoms, it will be good for them to mention those symptoms, that risky encounter, to the health provider so that they do additional tests for what's called acute HIV infection. And as I mentioned earlier, this is one of the periods during which the risk for transmission is actually highest because the number of viruses that are circulating in the body is very, very high. So those symptoms are also similar to influenza. They're similar to just a common sore throat. So when you combine those symptoms with a risky behavior encounter for that period of time, 2 to 4 weeks previously, it should prompt one to think of HIV. And then, of course, you do have, when HIV is advanced, then the rest of the time, they may have no symptoms at all. So as they say, it's hard to tell just by looking at someone whether they have HIV infection or not. Then the rest of the time is where someone has advanced HIV and they get the more recognized symptoms of HIV, weight loss, tuberculosis, meningitis, and other infections. Maybe we can hear about children from Dr. Matshaba, how children manifest when they have HIV infection.
Yeah, thank you. So again, I think the acute infection is probably quite similar. The difference is that children usually won't know what that is. Adults may remember that, but generally children don't. Mm-hmm. For those that are perinatally infected, so infected either during pregnancy or around the time of delivery, usually there are no signs because the infection is new, like he says, and you need time for that to build up. Those that get infected during pregnancy, before they are born, we sometimes get very sick children on day 1 of life. That's very rare. We've had a few cases here in Botswana. I don't know about in other countries, but it's very rare. It just shows that this baby was infected much earlier on in the pregnancy. And by the time they are born, they are now starting to show symptoms. So for the first few months of life, then we don't usually see a lot of symptoms. But by year 1, we start to see they stop growing as fast as they should. They start getting a lot more infections, flu-like symptoms and things like that, ear infections. It's a myriad of different types of infections, culminating in a child that doesn't grow very well. So it's very key that if the child has been exposed, they get tested as quickly as possible so that they get on treatment. If they are negative, you follow them very closely again for the other signs and symptoms that may come because of this infection. Again, once they get sick very quickly and tend to die rather quickly, unlike adults where you can take years before they start to show other symptoms. I think I'll end it there.
Thank you so much for sharing this information, Hannah.
Thank you. So we're going to go to diagnosis. How is HIV diagnosed, and what is the gold standard for an HIV diagnosis? Dr. Hachaambwa, you can start.
Yeah, so HIV diagnosed with an antibody test. It's a blood test. So you do usually 2 tests, one sort of to start with, and then if it's positive, you do another rapid test to confirm it. So in the general population, that's how HIV is diagnosed in general. You do 2 rapid tests, and then there's also another additional molecular test called PCR polymerase chain reaction that can also be used for diagnosis of HIV. That one is very sensitive. I mentioned earlier about acute HIV infection, so that would detect even acute HIV infection. It may not be available in all health facilities. And then now there's also the oral test that can be used using a swab that's done in the mouth. And again, you get the results within a few minutes. That's usually followed by a blood test to confirm. So that's how HIV is diagnosed in adults.
Thank you. And just a follow-up, maybe Dr. Matshaba, you can also address this, the issue of the take-home tests. What do you think about those? Are they as accurate as getting it with your doctor or nurse at the hospital?
Yeah, so the home test, yes, it is a good first test because there are many people that will not come to the health facility to get tested. So that's a good first step. It's actually been shown to be a very good test. Obviously, the sensitivity is different from the rapid test. So once that test is positive, it's supposed to be confirmed with the one that you do at the hospital. So that's being promoted. The HIV self-test, which is can be done in the privacy of one's home. So that's a recent innovation in HIV testing.
Thank you. Dr. Matshaba, do you have anything to add?
Maybe to start with the last one that Doc has just touched on, I think it's an important development, specifically for the subpopulations that are very difficult to get to. These are your key populations and men. So I think the self-testing usually works for these types of people who are unlikely to go to a healthcare facility. So it's a welcome development. They are generally quite accurate, but like Doc says, they are used for screening. You still need to go and confirm your test in the hospital. Just like the pregnancy test that most people know about. You still need to go and confirm. For diagnosis, the two general tests that he talked about are what we use in children as well. But unlike in adults, we tend to favor the molecular, he said the molecular or PCR test. This is because this test is much more sensitive. It picks up the virus itself. The antibody test picks up antibodies, which means you have to get infected. Then your body has to produce antibodies, and you pick up the antibodies that are fighting HIV. That's how you prove your infection. With children, unfortunately, at the time of delivery, they do get a lot of antibodies from their mothers. So what sometimes happens is if you test them with antibodies, you may actually be looking at the mother's antibodies rather than the child's antibodies and think that the child is infected, whereas they are not. So that is why for us, we prefer the molecular for the first year of life. After the first 18 months of life. After 18 months, we now start to use the antibodies, just like in adults, like Doc has mentioned. That's the big difference between adults and children.
Thank you so much. Dr. Matshaba, you said that PCR is the most preferred when testing for HIV in in adolescents and infants. Dr. Hachaambwa, which testing method is preferred or yields the best sensitivity when testing adults?
So for adults, the antibody test is what's used generally because it's more commonly available. The situations where we would want to start with the PCR is when you suspect acute HIV infection, the scenario that I gave. But for the rest of the population, we do start with the antibody test. And they have become sensitive. They can actually detect HIV infection fairly early on, a few days after infection. Let me say a few weeks after infection. The window period has been narrowed compared to what it was before. But the difference in young children, those less than 18 months, I think is what he mentioned, where the antibodies from the mother might give a false positive. But for adults, that scenario does not arise. So generally, we start with the antibody test. And then in situations where there's acute HIV infection, you could use a PCR. The PCR is not as readily available, but the antibody test is quick and is readily available.
Okay, thank you so much. And a follow-up question is there a cure for HIV? What happens next if you've been diagnosed with HIV?
Well, there's no cure at the moment, but life is different compared to what it was 20 years ago. So 20 years ago, most of Africa did not have access to life-saving treatment. And a lot of people died because of that. Also, about that time when treatment started, it had a lot of side effects, and there were people sometimes stopped because of side effects. And there were also a number of pills that needed to be taken, so the pill burden was quite high. So what's different now is that we have very effective treatment, that if somebody takes that medicine, they can live a healthy life just like anybody else who does not have HIV infection. So while there's no cure at the moment, treatment is so effective that it makes the life of someone with HIV not too different from someone who takes medicine for hypertension, for example, or any other chronic illness that someone may have. And the lifespan is also actually prolonged. Someone with HIV can live as long as their peers, especially when treatment is started early before it's caused a lot of damage. So there's no cure at the moment, but the treatment is very effective, that it makes the life of someone with HIV quite similar to someone who does not have HIV apart from taking the medicine.
Thank you.
Just to follow up on the treatment, Dr. Matshaba, I read somewhere about ART treatment. I don't know if you know about it. Could you share more information on it and how it works?
Oh, thank you. I think the ART stands for antiretroviral treatment. So this is a treatment cocktail that we use to suppress the virus from multiplying. A virus that multiplies usually causes a lot of damage and harm to the body, which now exhibits as signs and symptoms and sometimes ends up in death. So to prevent that, we give a cocktail of drugs called antivirals, because they fight viruses and they fight the HIV virus. They generally, in most concoctions, we have 3 drugs. And the reason for that is that we want to prevent them from getting a resistance, because the virus learns about these drugs if you use them over time and they stop working. But if you use 3, just like in many other diseases, including tuberculosis, you prevent that from happening. So ART means that concoction that we give to people and they live long and happy lives. I think we have come a long way as a community, because we came from around 15 tablets per day, if you remember, Doc, in the early days, to 1 tablet a day. That 1 tablet still has 3 different medications in it. And so it still constitutes ART that you are asking about.
Thank you for that information. And so are there any side effects to the current treatment, to the current ARTs, or is because you mentioned that before, when it first came out, there were a lot of side effects. Do we still have that now, Dr. Hachaambwa?
Yes, so again, just to emphasize that the medicine that we have now is much, 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 much better than what was there before. But there's hardly any medicine without side effects. So there are minimal side effects. So I'd say there are some side effects, but they're very minimal and well tolerated. So the commonly used ART combination that's used in this part of the world and in other parts of the world, it's combination of 3 drugs. The main side effect that probably potentially could happen is sometimes there's an effect on the kidney long term, but again, very few people have that. And that's actually being replaced with another drug that doesn't have that side effect to the same degree. Just about up until 2 or 3 years ago, the main treatment that was used had a side effect of dizziness. So one of the drugs had a component that caused dizziness, sometimes difficulty with sleeping, and some issues with vivid dreams and all those. But that's again been replaced with a much safer, better tolerated drug. So overall, the drugs that we're using at the moment have very minimal side effects and generally well tolerated. there could be a few issues here and there in some people, but that would be in the minority of the population that they're hardly worth mentioning.
Thank you. And Dr.
Matshaba, I know Botswana has done quite a bit of work on this. Maybe you want to elaborate more with the current treatment?
No, I think you have covered it very well. Generally, the earlier treatments had a lot of very bad actually side effects, and a lot of them, actually, people were killed by the drugs because of the side effects. There were some of the drugs that have now been decommissioned that caused the liver damage, for example, or very bad reaction where people's skin will just peel off and they get infections and die. But now we have done really well in terms of reducing the side effects. So the current medications, like Doc says, they have mild side effects. If you take your paracetamol or Panadol, or whatever you use in your part of the world, it also has side effects. So no single medication has no side effects. But the side effects that we have now with our new treatments are mild and generally tolerable. If you continue using the same drugs, they most of the time actually disappear over time. So in terms of the new formulations that now the whole world is using, like he rightly says, we started using this quite earlier on. And we are just really impressed by the number of side effects we're getting. It's very, very few, including in adolescents.
I'll probably just want to add one more thing about the new medication that we're currently using. Not only are they well tolerated, they're also very, very effective. So they do a good job in getting the viral load to undetectable levels. So that those two things, tolerability and effectiveness. So that makes life so much better for our populations that are on treatment.
Thank you so much. So speaking about tolerability, could you share more information about drug resistance and intolerance? What is it, and what do people who have drug resistance and intolerance go through?
So Dr. Matshaba mentioned earlier that we use 3 drugs because if you use one drug, there's a risk of developing resistance. So the virus is undergoing constant changes. It's undergoing mutations. And some of those mutations confer resistance. They make the virus less susceptible to the medicines that we're giving. So if one was to use one drug, there would be a risk of the drug eventually not being as effective. But combining the drugs, the 3 drugs, reduces that risk of resistance. So resistance generally occurs when people are not adherent to the treatment, because you need a certain level of the drug in the body for it to work. So there's a threshold above which the drug needs to remain. So the quantity of the medicine in the body needs to remain above a certain threshold. If it falls below that threshold, then the virus may have a chance to multiply and eventually overcome the effectiveness of the drug. And again, going back for us, maybe I'll say 2 years ago or 3 years ago, Botswana much longer. The drugs that we used to use before, resistance would develop very easily. If someone stops taking medicine, so if someone takes medicines today, then in 2 days, they miss for about 3 days, and then they restart. So that kind of behavior easily leads to resistance. And that was more common with the drugs that we had. It can happen.
Did I lose audio? Or?
No, I think his screen has frozen.
Okay. No, I mean, I can continue where he left.
Yes, please.
Yeah. So specifically for children, there are different ways of getting this resistance. One is that it can be transmitted, i.e. when they get the virus from their parents, they also get the resistant virus. So the virus comes already resistant. or else it could also be transmitted through, developed through poor adherence. So if you are not taking your medications well, like the doc was saying, then you can develop resistance. Because of all of this, then sometimes what we do is we study what types of resistance you have, and we change your treatment to the drugs that the virus will respond to. It's generally not desirable because the drugs that you go on to usually are much more harsh compared to the first line, and they are more expensive. So we try as much as possible to keep people on the first line, which is much simpler, much cheaper, and much more tolerable than the higher levels. Yeah.
Thank you for that. And I've seen a lot of conversations on social media about U equals U, undetectable is equals to untransmittable. Could you elaborate on what that means?
Yeah, for one to transmit the virus needs to be circulating in the body. So from the beginning of the epidemic, we knew that people who are not on treatment, people who are not suppressed or the virus is still visible in their blood, when they have unprotected sex, they are likely to transmit the infection. So what we have learned in the last 4 or 5 years is if the virus is suppressed to very, very low levels, even if these people with suppressed virus have unprotected sex, they don't transmit the virus to their partners. So that is how the U equals U has come about. I think during the last 2 years specifically, it became something that was shared with the rest of the world because as motivation for continuing to be adherent, we wanted to use it positively, that being suppressed has other benefits beyond just to the self, but to the partners as well.
Thank you. And as a follow-up question, you mentioned relationships. Could you speak on discordant couples, what that means, and yeah.
Yeah, a discordant couple is one where one partner is HIV positive and the other is not. So in that case, they are discordant because their status, HIV status is different. So that's where the discordance comes from. It's an important couple to know because I think with full information, those couples can go on and survive all these issues that people are afraid of. Because usually when you think of discordant, you will think the negative one may want to run away and find other negative partners. But in our experience in Botswana is if they are disclosed to, informed together, generally they stay together because it's something that you can overcome by protecting the HIV negative partner, either using condoms as we talked about earlier, or using PrEP that has been rolled out in most countries so that the uninfected remains uninfected for the longest time. Yeah.
Thank you. Natasha?
Thank you so much. So I was wondering, how far are we from discovering a cure for HIV? Because as you have explained so well, over the years, the type of medication has changed from the number of pills you need to take, even the detection has changed. So how far are we from discovering a cure?
Yeah, that's a very important question and difficult one to answer. HIV is a finicky virus in that it changes over time. As it changes, whatever you are developing now may work for the next couple of years. And generally, by the time you try and roll it out into the general public, the virus has changed enough for that vaccine or medicine not to work. So because of that, we've had a lot of false hope over time that this will happen, because we got very close a couple of years ago and 5 or 10 years ago as well. But the problem is that it changes so quickly that it's very difficult to develop a vaccine. Compared to COVID, which we have now, From last year up to now, it hasn't really changed that much, which is why we have a vaccine coming out. But if it were to change every month, I'm just giving an example here, then you would not be able to come up with a vaccine. So HIV in its lifespan over the last 30 years has changed so much that it's very difficult to develop vaccines. But with new technologies that we saw with COVID, I think you have heard of the mRNA vaccines that have been developed, the ones that are being rolled out as we speak. And maybe this new technology will come up with different ways of inducing our immune system to fight HIV and hence prevent it, because that's how vaccines work. I hope it's clear and not confusing.
Yes, it's very clear. So we're hopeful that a cure will come soon with the advancement in technology. Have you heard of the functional cure, which is using the bone marrow transplant? If so, could you please elaborate more on that?
Yes, we've heard of those, although the cases are very, very few around the world. We've heard, I think the first one called the Berlin patient, where a patient got infected with HIV and then developed some form of cancer. As part of treatment for the cancer, the bone marrow was removed. And in doing that, with the chemotherapy for cancer, in doing that, we realized that the body was actually cleared of the stored virus that keeps coming back for most people. So that gave us the opportunity that there is another window where people can be cured. But unfortunately, the problem with that is, one, it's not very easy to do in most countries. I'm talking about bone marrow transplant. It's a very delicate process. Two, we don't know if it's other people with different types of genetics and heredity, if it will work the same way. Because most of the people where this has worked has been in the Caucasian population. Three, the long-term side effects are not known. Unfortunately, the Berlin patient actually passed on this year, succumbing to new infections. So I think, yes, it's an interesting and intriguing area of for research, but it is not yet at a stage where we can talk about it for the masses. Dr. Hachaambwa, welcome back. We are just talking about the Berlin patient and a functional cure, and if there's any hope around that.
Yeah, thanks. Apologies once again, my internet failed me. So just to mention again what's been said, that all that worked for that patient because of that mutation in the blood that was infused, the stem cells that were infused. On a wide scale level, that's really difficult to implement. So bone marrow transplant is a very complicated thing. A patient who's at the transplant requires to be isolated, kept from infection, and there are actually many risks of infection that could actually lead to death just from the transplant itself. So from a practical point of view, that showed, I think, the concept that if the concept of the function cure, that if something can be found that's not as aggressive as that takes care of the problem the way it was taken care of in that patient, there's probably a possibility in future of a functional cure. And there are many people right now that are doing research focused on this. So we hope in future we'll get to that point. But using that same kind of thing is really not practical for day-to-day practice. Thank you.
Thank you for highlighting that. So bone marrow not for broad application for everybody at the moment.
No.
So we're going to move on to HIV and comorbidities. Dr. Hachaambwa, would you like to perhaps speak on that for a bit?
Yeah, so what I'd probably want to highlight is that as we get most people on treatment and they will remain healthy, for those that started treatment late, that had many years of untreated HIV infection, there was a lot of inflammation that was going on in the body. And that inflammation causes other problems in the body that sometimes we don't even think of being HIV associated. When we think of HIV, we think of severe infections like tuberculosis, meningitis, and other such things. But having untreated HIV for many years causes chronic inflammation, and the body's response to try to fight the infection causes collateral damage on other parts of the body. So the one that I would like to highlight is the risk for cardiovascular disease. So we think of heart disease as having risk factors such as obesity, high blood pressure, high cholesterol, but HIV infection itself is a risk factor for heart disease. And that's mainly because of the immune response that was going on while the HIV was not treated. So heart disease is one comorbidity, one condition that occurs together with HIV and is a risk factor. And then others, certain types of cancers. And again, these may not even be HIV related. Then things like strokes, having a stroke where there's a problem in the brain where blood flow to a part of the brain is not very good and part of the body becomes not very functional. So strokes are some of the things that you can think of that HIV increases risk for those additional conditions. And then of course, we have the big burden of tuberculosis, which comes because of immunosuppression, the immune system being reduced in HIV infection. Yeah, but there are several things that we ought to continue looking out for in our population with HIV infection, even when they're healthy, especially cardiovascular disease, stroke, cancers. So we should be screening for those conditions, and we usually do look for those things. They'll come earlier than their age mates. For example, people have strokes when they're older, in their 60s and 70s. It could come earlier. People have heart disease, again, much older, similar to other issues like dementia. They could come slightly earlier if HIV is untreated. And that's all the more reason why everyone should be on treatment early on. So at that period where HIV is untreated gets reduced. I think that's all I have to say for now.
Thank you so much.
So I'm just a bit curious because I'm working with cancer, and I know that in Africa we have seen a younger population with cancer cases. Is there a link in any way, since you're saying that HIV could, cause some of these comorbidities to occur earlier?
Yeah, there are obviously a number of other factors that lead to cancer, but and again, it's not every type of cancer. There are certain types of cancer that are actually HIV associated, but there are others that are not a direct result of HIV. So for some of them, yes, in HIV infected populations, occurring in younger populations, and much more commonly, it could be related to untreated HIV. But of course, this is coming together with other risk factors, obesity, for example, causing colon cancer and other things like that. So it's sort of, what can I say? Instead of a double burden, triple burden, or quadruple burden of disease, several things coming together to play on the African population.
Thank you so much. I have a follow-up question now that we're talking about comorbidities. Dr. Matshaba, what is the difference between HIV and AIDS? So for people who would want to know, what is the difference? Is it when somebody becomes immunosuppressed? So tell us more on that.
Okay, thank you. The virus that causes AIDS or HIV, the HIV virus, is a virus that, like we have talked about, gets transmitted at one point from one person to the other. Once the person gets infected, what happens is the body starts to fight this infection on its own. During that period, while you seemingly normal, no issues, you are HIV infected. So that is the HIV infection phase. But as your body starts to lose the fight and you start now getting either comorbidities like we're talking about, or co-infections that come because of HIV, you can get TB, you can get cancers and all these other things. Now your body starts to fail. You reach a point where we now say you have AIDS. AIDS means you have, you are essentially losing the fight against the suppression of this virus. Naturally, the body fights any infection that comes into the body. May it be flu, may it be COVID, for example, may it be a TB. But once you move from the infection phase to the AIDS phase, it means your immune system is now not able to cope and handle that infection. I don't know if, Doc, you want to add to that.
No, I think that's pretty much it. Yeah. So that's the difference, and we want to avoid getting to that point of AIDS.
Yes.
So not everyone. So in summary, not everyone who has HIV infection has AIDS.
Yeah.
Yeah.
And just to buttress what you talked about in terms of the comorbidities, in children, what we worry about the most is a child is a rapidly growing human being. And during that phase of development, if you are infected with HIV, it can actually affect the growth and development. So for us, cognitive or brain development is very, very important for a child to grow up and be a normal adult later on in life. So as pediatricians, we spend a lot of time on normalizing this infection, i.e. catching it early and making sure that the child gets stimulated just like any other, so they start to grow and have proper brain development. Because if not, they are going to struggle with education in schools and things like that. So for us, on top of the issues that Doc talked about as comorbidities, developmental issues are key. By the time the child reaches the age of 2, 90% of the brain would have grown, reached almost full adult development. Then from then to around late teens, then the rest of this growth takes place. So it's very, very key that early on we protect this growing brain, so that for the rest of their life, they don't have to deal with the deficits or deficiencies. I just wanted to add that to Doc's comments.
Thank you so much.
Thank you. So still on comorbidities, I just wanted to find out if you have any insights on HIV and COVID-19, and if the pandemic has affected access to ARTs, particularly in African countries, because I understand that a lot of our ARTs come from abroad. Dr. Hachaambwa?
Yeah, so that obviously will probably differ from country to country. So the COVID-19 has affected everything, unfortunately. So like you rightly pointed out, one of the biggest concerns was that because our drugs come mainly from India, and so when there was that disruption in travel, so there was anticipated going to be delays in availability of drugs. So in anticipation of those things, what we ended up doing in Zambia is ensure that people who have HIV infection had access to at least 3 months worth of medicines, and in some cases 6 months, so that during this period they didn't have to, they didn't run out of drugs. And then the other thing was because of health facilities themselves being potential sources of COVID-19. So there was reduced trips to the health facility. So people were kind of encouraged to go to the health facility when they really had things going on that needed attention. So what we did is call people early on in the pandemic, to come and collect 3 to 6 months worth of supply. And obviously along that path, there are some who probably fell off the bandwagon. They stopped coming for their treatment, and some may not be as adherent now. sometimes just going to see the provider, even though everything is okay, kind of reinforces that message of adherence. So when the space kind of lengthens, so we're still looking to see what some of those effects have been in terms of adherence and also people stopping their treatment altogether. But those were some of the challenges that we're facing. Interruption in drug supply and also not going to the health facility as much as before. Not sure what happened in Botswana.
Yeah, same happened. I just happened to be in the task force that deals with COVID. So we were dealing with this from both angles. I think, like you rightly say, the lockdowns, for example, prevented people from accessing healthcare. Even after you removed the lockdowns, people were still afraid of getting out of their houses because they would likely get infected along the way on the bus or whatever mode of transport they need to get to. We saw this much worse off with, we do have a subset of our patients who also have cancer on top of that. So in that subset, they actually never left the house because they have this double hit with HIV and now you also have cancer and your immunosuppression drugs. So we saw that as a big issue. To get around that, we had to come up with innovative solutions. We've used WhatsApp and all these other ways to check on people and gave them multiple months supply like you did. I think we did exactly the same things. Specifically for adolescents, I think it was even worse because a lot of our interventions are not just your regular counseling. They attend teen clubs, they attend all these other psychosocial supportive events, which are now banned by most countries. So I think the impact on their mental health, I think, has been quite dramatic. We are hopeful that as things ease up, they will start to get more access to support services as well.
Thank you so much. So since today's topic, we also really wanted to touch on the stigma and misconceptions attached to HIV and AIDS. Throughout your careers as doctors, what are some of the misconceptions and stigmas that you have learned of? And HIV and AIDS medications, are they free or do you have to pay for them? Because, you know, sometimes people may be reluctant to go to the healthcare providers because they think they have to pay for them so much money. So what are some of the stigmas you've heard of during your practice?
So one of the misconceptions about HIV infection that I've consistently come across is someone thinking that if I get a diagnosis of HIV today, I'm going to die tomorrow. Or not literally, but generally the perception has been that when you get an HIV diagnosis, it's a death sentence in the immediate future. Despite all the information that's there, I think it's a bit difficult when it really hits home hard when the diagnosis is on the individual. They can't avoid but think that I'm not going to live long. So part of sometimes my work early on when someone just comes with a new diagnosis is to spend time explaining the things that we've just been talking about, that in this day and age, we have very effective treatment that reduces the risk of dying. So that's a misconception that someone is going to die right away because they have an HIV diagnosis. And then the other misconceptions, especially the ones that spread stigma, is that when someone sees an individual with HIV infection, is to think, oh, they're promiscuous, how did they acquire HIV infection? But people have no idea of circumstances that led to someone's acquisition of HIV. So that judgment of an individual because they have an HIV diagnosis, I think that's one of the things that really drives stigma. So those are things that we need to work against. And then of course, the other ways that they think that if someone has HIV if you share something with them, even ways that HIV cannot be transmitted, people think that HIV will be transmitted. I think those are three that I can point out off the top of my head.
Yeah, on the pediatric and adolescent side, the only, well, not unique, but more prevalent one is what we term self-stigma. So I think it's a lot more prevalent in adolescents and young people than in the adult population. You can correct me, Doc, if that's not correct. What we see is an adolescent or young person who's infected with HIV who decides to dissociate from the society because they think people are looking at them negatively, they are judging them, they are doing this. This prevents them from getting the right support. It's a mental barrier that they have to overcome if they are to essentially get help. So for young people, we have programs that tries and train them in being assertive, in being taking care of their own health and being responsible for their own health, because that's a key component for long-term, lifelong adherence and success on treatment. The rest of the stigmas that he talked about, essentially, we see here as well. There may be other cultural practices that also predispose certain families to stigmatizing, to being stigmatized within the community because people don't understand how the transmission takes place. So once a household has HIV, people think that everyone who passes by that house will get HIV. It's a very painful part of the society actions that can actually make our fight against this infection much more difficult. Yeah, I think the rest are the same as what Doc has talked about.
Thank you for highlighting that. Before we wrap up, I think there's just a few terms that you've mentioned throughout this webinar that would be great to kind of explain. And one of them is proper condom use. What does that mean and what is it? And the second one is PrEP. I know we briefly touched on it, but when do people use it? Can I just go to the pharmacy and get it? And is it safe to use regularly?
Okay, so start with the last one. So PrEP, when someone thinks they're at substantial risk for HIV infection, they can go to a health facility, or in some situations, actually community posts where people can access those services. And there'll be a screening questionnaire. There'll be questions that will be asked to assess the risk for HIV infection. And then someone would be advised whether they'll be candidates for PrEP or not. And then instructions will be given of how it's supposed to be taken. But in general, as long as the risk continues, then somebody's supposed to continue taking PrEP. So PrEP works if it is taken. So medicines work if people take them. So if someone is on PrEP and then sometimes they take the drug, sometimes they don't, it may not work as well. But all that counseling will be done when you go to a health facility and are advised based on the risk factors that are given.
Thank you. And Dr. Matshaba.
For the correct condom use, I think we generally assume that people know how to use them. I think in the adult population, it's probably more correct than in adolescents. But for adolescents, actually, you have to start with the basics as to how to safely handle it, how to use it properly. The other key thing is when to use it. I think a lot of people are not aware that even during foreplay, actually, you can still get infections. They assume that it's only at the time of the actual act where it needs to be used. So by correct condom use, that's what I was referring to, as to how to safely handle it, how to safely dispose it afterwards, how to use it and when and how to use it properly. I think for adolescents, this is key because if they don't have this information, they will in their head think they are protected, whereas they are not. Disposal is key. I think people only stop sometimes teaching adolescents how to use condoms all the way up to the act. But beyond the act, they don't talk about the disposal, where people are still exposed to potential infection. Doc earlier talked about mucosal membranes. These are membranes that you find in the inside of your eye and your mouth and the genital areas as well. So even after the act, if you don't dispose it properly and you touch your eye or your mouth or all these other areas where the infection can come through, you are still exposed. So it's key, not just because they can read, you tell them that this is how to use a condom, but you actually go to that level of detail.
Thank you for that. I think we've come to the end. Before I call Dr. Asombank, I just want to say thank you. It's been an honor having this discussion with you. I've personally learned a lot, and we've come a long way with HIV. There's still a lot to be done, and thank you so much for your contribution in the field. Dr. Asombank.
Thank you so much as well. Before we wrap up, in case the doctors have any last words to share, you can please share them with the population that's watching us live on Facebook and on the Zoom call. And Dr. Hachaambwa, you could also talk about your Center for Excellence and what you do and what are you currently doing, Dr. Matshaba.
Well, thank you, Natasha and Hannah. It's been a pleasure having me on this, having us on this platform. Yeah, so just the last words, I think I would probably just want to emphasize that we do have effective treatment for HIV these days. In 2020, people who have HIV infection can live healthy, happy lives just like their colleagues who do not have HIV infection, but just taking one pill a day, which has very minimal side effects. Then in terms of my current work, I do some clinical work we do have a Center of Excellence in Lusaka, University Teaching Hospital, Lusaka. There's both a Pediatric Center of Excellence and Adult Center of Excellence. I work at the Adult Center of Excellence, where we provide HIV care, complicated HIV care. There's screening for cervical cancer, and there's some lab work going on there, both for HIV molecular work, which I talked about earlier on. And then I'm also involved in University of Maryland programs here in Zambia, focused mainly on adolescent girls and young women and key populations, mainly focusing on HIV prevention, and also do some teaching and some research on HIV mortality as well. Thank you.
Yeah, thank you. And I think I've also appreciated the time and the platform to talk to you and your viewers across the world. We hope that this time we have spent together, we have passed on some of our lessons that we have learned over the years, and hopefully most people will find that useful. For adolescents, I think all I can say is let all the programming, like Dr. says, works with the dreams. Let all the work reflect involvement of these young people in designing solutions for their care. I think if we can do that, we will walk in their shoes and hopefully come up with more effective solutions that are acceptable to them and their changing circumstances. Just like Doc says, we have a large Center of Excellence here in Gaborone, overseeing quite a lot of young people. Majority of our clients are now young people. We are seeing very, very few infants and small children come into the program. We do training, research, clinical work, as well as support to the government agencies and committees that do guidelines as well at policy level. So I think this has been a pleasure. I appreciate the opportunity.
Yeah, I've actually enjoyed this as well, as a gastroenterologist learning about HIV/AIDS. I've learned a few things. So I am absolutely grateful to both of you, for taking this time. It's been almost 2 hours, so you're taking this precious time on a Sunday. So really appreciate your time, and then obviously Hannah and Natasha. Thank you both as well for co-moderating this session. This has been streamed live on Facebook, so people could obviously go back to it. And we hope to have more sessions in the upcoming year. And I'll definitely reach out to both of you again, for any future conversations. So on behalf of POHER, for the month of December, this is probably this might be actually our last educational series for the year. So what a powerful way for us to go out. You've talked about a lot of things. And I think as we explore all these different diseases, I think, one of the key messages we want to get out there is about the stigma associated with some of these diseases, because, we do believe that this does negatively impact care overall. Indirectly or directly impacts mental health and other conditions. So we really appreciate, how well you explain things to the audience. And on that note, to everyone who's watching, listening, or planning to watch later, good morning, good afternoon, good evening, and have a wonderful day and have a wonderful week on behalf of POHER. Thank you so much. Everyone take care. We'll talk to you later.
Thank you.
All right.
Bye, thank you.
All right, take care.